Hi, this is the presentation of the movement analysis of hair brushing, which will be presented by Malia Prevost and Alexis White. Before we get started, let's take a look at the importance of hair brushing. Brushing your hair will activate the blood circulation in the oil glands in your scalp. It also conditions and strengthens your hair from the scalp stimulation that occurs from the hairbrush that helps distribute your natural hair oils evenly through the hair, aiding in hair growth. Let's take a closer look at the dynamic movement of hair brushing. There are three different phases of movement throughout hair brushing. The first phase is the preparation phase, also known as the initial range of task. The second phase is the execution phase, known as the mid-range of task. And the third phase is the termination phase, also known as the terminal range of task. In the preparation phase, initial posture and right arm reaching to hairbrush occurs here. Let's take a closer look of the movement that occurs at the preparation phase. The joints, movement, and muscles involved at the preparation phase are listed in the order of activation in which they occur, which include shoulder flexion at the glenohumeral joint with concentric contraction of anterior deltoid, pectoralis major, coracobrachialis, and biceps brachii, slight internal rotation at the glenohumeral joint with concentric contraction of anterior deltoid, latissimus dorsi, teres major, subscapularis, and pectoralis major, scapular protraction at the scapular-thoracic joint with concentric contraction of the serratus anterior and pectoralis minor, forearm pronation at the proximal and distal radial ulnar with concentric contraction of pronator teres and pronator quadratus, elbow extension from elbow flexion at the humeral ulnar and humeral radial joint with concentric contraction of triceps brachii and aconis, neutral position at the radiocarpal joint, which includes isometric contraction of the flexors and extensors of the wrist, digit extension at the MCP, PIP, IP, and DIP digits 2 through 5 with concentric contraction of extensor digitorum, extensor indicis, and extensor minimi, and digit abduction at the MCP joint with concentric contraction of dorsal interossi.
During glenohumeral flexion, the prime mover is the anterior deltoid, with assistance from the pectoralis major, coracobrachialis, and the biceps brachii. These assister muscles are also known as synergists. Also listed on this slide are the antagonists, which are the muscles that produce the opposite movement of the agonist. The fixators are the muscles responsible for stabilizing the joint during the desired movement, and the neutralizers, which prevent unwanted movement like the fixators, except that they act against the unwanted movements produced by the prime mover itself. Optimal range of motion of the glenohumeral joint in flexion is 120 degrees, 180 if full scapular upward rotation is available. Glenohumeral flexion was 68 degrees during the preparatory phase and was assessed using the Kinesiology program. The prime mover during elbow extension is triceps. The synergist is anconeus. The subject's elbow extension was measured at 177 degrees using the Kinesiology program. Pronation from the anatomical position rotates the palmar surface of the hand to face backwards. In the provided picture, however, the palmar surface of the hand is rotated downward to face the floor. This movement happens at the radial ulnar joint. Prime movers are the pronator teres and pronator quadratus. Digit extension is when the fingers are stretched out straight. Listed are the extrinsic and intrinsic muscles that are responsible for these specific movements and the joints that they act upon. The extrinsic muscles are the long flexors and extensors, and they're named extrinsic because the muscle belly is located in the forearm, where the intrinsic muscles are smaller and are located within the structure of the hand. Digit abduction is the action of spreading the fingers apart away from the midline of the hand. Both digit extension and abduction are in preparation for grasping the brush.
In the execution phase, grasping and manipulating the hairbrush and the execution of brushing the hair occurs here. Let's take a closer look at the movement that occurs at the execution phase. Grasping the brush with a cylindrical power grip and bringing the brush up to the crown of the head on the right side occur in the execution phase. The joints, movement, and muscles involved are listed in the order of activation in which they occur. Furthermore, they are color-coded to assist as a guide for when each motion occurs, which include digit flexion at the MCP, PIP, and DIP digits 2 through 5 joints, with concentric contraction of the flexor digitorum superficialis, flexor digitorum profundus, and flexor digiti minimi brevis. Wrist neutral position at the radiocarpal joint with isometric contraction at the wrist flexors and extensors. Shoulder flexion at the glenohumeral joint with concentric contraction of the anterior deltoid, biceps brachii, pectoralis major, and coracobrachialis. Shoulder elevation at the scapulothoracic joint with concentric contraction at the trapezius, rhomboid major, rhomboid minor, and levator scapulae. Shoulder abduction at the glenohumeral joint with concentric contraction of the deltoids and supraspinatus, and scapular retraction at the glenohumeral joint with concentric contraction at the trapezius, rhomboids major, and rhomboid minor. Additional joints, movement, and muscles involved, bringing the brush up to the crown of the head, include elbow flexion at the humeral ulnar and humeral radial joint with concentric contraction of the biceps brachii, brachialis, and brachioradialis, forearm supination to neutral position at the proximal and distal radial ulnar joint with concentric contraction of the biceps brachii, supinator, and brachioradialis, wrist extension from flexion at the radiocarpal joint with concentric contraction of extensor carpi radialis, longus, and brevis, and extensor carpi ulnaris. Digit flexion at the MCP, PIP, and DIP joints digits 2 through 5 with isometric contraction of the flexor digitorum superficialis, flexor digitorum profundus, and flexor digitorum minimi brevis. Combing through the hair includes shoulder adduction at the glenohumeral joint with concentric contraction of the deltoids and supraspinatus, shoulder depression at the scapulothoracic joint with concentric contraction of the trapezius, rhomboid minor, and levator scapula, elbow flexion at the humeral ulnar and humeral radial joint with isometric contraction of the biceps brachii, brachialis, and brachioradialis, forearm neutral to forearm supination at the proximal and distal radial ulnar joint with concentric contraction of the biceps brachii, supinator, and brachioradialis, wrist flexion at the radiocarpal joint with concentric contraction of the flexi carpi radialis, flexor carpi ulnaris, and palmaris longus, and digit flexion at the MCP, PIP, DIP digits 2 through 5, with isometric contraction at flexor digitorum superficialis.
The prime movers of the glenohumeral abduction movement that occurs during the execution phase are the anterior and middle deltoids, assisted by the supraspinatus. Optimal range of motion, again, is 120 degrees, 180 if full scapular upward rotation is available. Glenohumeral abduction was measured at 79 degrees. Full shoulder abduction or flexion requires the coordinated motion of the scapula and the humerus. This relationship is known as the scapulohumeral rhythm and occurs at a 2-to-1 ratio. For every 2 degrees of humeral flexion or abduction, there is 1 degree of scapular upward rotation. The prime movers responsible for scapular upward rotation is the serratus anterior, assisted by the upper and lower trapezius. Normal range of motion for a healthy shoulder is 90 degrees of external rotation. Prime movers of external rotation are the infraspinatus, teres minor, assisted by the posterior deltoid. When bringing the brush from the table to her head, the subject performs elbow flexion. The prime movers of this action are the brachialis, with assistance from the bicep brachii and the brachioradialis. Optimal range of motion of elbow flexion is 150 degrees. Elbow flexion was measured at 145 degrees. The subject's wrist is isometrically contracted in the neutral position. Digit flexion is activated when making a fist or grasping an object. Listed are the extrinsic and intrinsic muscles responsible for this complex movement. The adductor pollicis and palmar interossae are the intrinsic muscles which are responsible for digit adduction, which is the movement of the digits towards the midline of the hand.
At the termination phase, returning to the initial posture that was mentioned in the preparation phase occurs here. Let's take a closer look at the movement that occurs in the termination phase. The joints, movement, and muscles involved at the termination phase include scapular protraction at the scapulothoracic joint with concentric contraction of the serratus anterior and pectoralis minor, shoulder flexion at the glenohumeral joint with eccentric contraction at the anterior deltoid, pectoralis major, coracobrachialis, and biceps brachii, elbow extension at the humeral and humeral radial joint with concentric contraction of the triceps brachii and acones, forearm pronation at the proximal and distal radioulnar joint with concentric contraction of the pronator teres and pronator quadratus, neutral position at the radiocarpal joint with isometric contraction of the flexors and extensors of the wrist, digit extension and digit abduction at the MCP, PIP, DIP digits 2 through 5 with isometric contraction of extensor digitorum, extensor indicis, and extensor minimi and dorsal interossi, and elbow flexion at the humeral ulnar and humeral radial joint with concentric contraction of the biceps brachii, brachialis, and brachioradialis.
Glenohumeral adduction is the action of bringing the upper extremity towards the body or midline. Prime mover is the latissimus dorsi. Synergists are pectoralis and teres major, coracobrachialis, the long head of triceps, infraspinatus, teres minor, subscapularis. During terminal phase, glenohumeral adduction was 18 degrees. Scapular downward rotation is when the inferior angle or the bottom tip of the scapula moves towards the vertebral column or midline of the body. Scapular downward rotation is an action of the scapulothoracic joint. The scapulothoracic joint, however, is not a true joint. It is the term used to describe the articulation of the scapula on the thorax. Prime mover of internal rotation, depicted here in this picture, is the subscapularis. Synergist muscles are anterior deltoid, pectoralis major, latissimus dorsi, teres major. Optimal range of motion of internal rotation is 60 to 70 degrees. Full elbow extension is 180 degrees. Prime mover is the triceps with assistance from the anconeus. This picture shows elbow extension of 50 degrees at the completion of the hairbrushing task. This is prior to returning the brush to the table, which was measured earlier as 177 degrees. The supinator muscle is the prime mover in supination and is one of the most difficult muscles to remember. It is assisted by the bicep brachii and the brachioradialis. In order to release the brush, we return to our start position of digit extension and abduction, as previously described.
To summarize the whole movement analysis, the following biomechanical movements are observed. The movement is a circular movement from the glenohumeral joint, moving from neutral position to flexion, abduction, external rotation to adduction, internal rotation to neutral position to complete the task. The humeral ulnar and humeral radial joint moves from 90 degrees of flexion to 0 degrees of extension with pronation at the proximal and distal radial ulnar joints. During execution of hairbrushing, flexion occurs at the humeral ulnar and humeral radial joints. After task completion, the humeral ulnar and humeral radial joint moves back to 0 degrees of extension with pronation at the proximal and distal radial ulnar joints and to the resting position of 90 degrees of flexion at the humeral ulnar and humeral radial joint.
The musculature of the body contributes in a large part to the stability of the body and its ability to maintain balance and symmetry. Weakened and overstretched muscles in combination with overactive and tight muscles has a powerful impact on the alignment of the body. The following assessments are static postural assessments and can be beneficial for initial assessment and identification of an imbalance, helping the practitioner narrow down areas of imbalance, which allows for improved clinical reasoning when determining the movement assessments to administer. There were no obvious deviations in the movement analysis. However, if we examine the subject's posture, we can see some issues. In this lateral view, the first picture shows her sitting at rest. The subject has rounded shoulders, and the plumb line passes through her acromion process, however, falls behind her ear, demonstrating a forward head position. This is typical of an upper cross syndrome. When the subject reaches for the brush placed on the table, there is an increase in the rounding of the shoulders, the head moves further forward, and the curve in her low back increases. Upper extremity movement impairment syndrome is a predictable pattern of movement impairments. This, along with upper cross syndrome, are often observed in individuals who sit for long periods. They are characteristic of rounded shoulders and a forward head. Upper extremity movement impairment can also present as atypical kinematic activities of the scapulothoracic or glenohumeral joints while performing functional movement. Here is a list of muscles that are overactive and ones that are weak in upper extremity movement impairment syndrome. This postural deficit is similar to upper cross syndrome. Note the muscles marked with an asterisk are involved in upper cross syndrome. You will notice very minimal differences. Lower cross syndrome is another common postural deficit that we might be seeing here and is characteristic of increased lumbar lordosis and an anterior pelvic tilt. Here are a list of common muscles that are too tight and others that are too weak that contribute to this imbalance. In this picture, we see a posterior view of the subject as she is performing the hairbrushing activity. Note that the plumb line is centered on her spine and sacral area. However, her head deviates to the left side, and there is a slight elevation in her right shoulder and left hip. Also note the asymmetric creases at her brassiere and waistlines. It is unclear from this picture whether these are due to muscle overactivity and weakness, or if the subject has scoliosis, which is a lateral curvature of the spine. An alternative cause may also be the placement of her feet on the chair legs, providing little stabilization of the trunk. To address these deviations, I would first have the subject place her feet flat on the floor and assess again. Based on those results, determine which movement assessment to perform. This information would give indication of muscles that need to be strengthened or stretched. It would be beneficial to educate the subject regarding proper body mechanics and ergonomic techniques to decrease the effects of gravity which cause these postural deficits. Corrective exercise is the process of improving movement impairments through proper exercise techniques. Movement impairments are identified through a series of assessments, such as the overhead and the single leg squat that we used in class. There are several others, for example, the star balance excursion test and the tuck jump test. Once a problem has been identified through assessments, then the practitioner can develop an appropriate plan of action based on the impairments identified and set goals. Key to success in seeing desired outcomes is implementing effective corrective exercise strategies with an emphasis on proper exercise technique.
Thank you for watching our presentation on the movement analysis of hairbrushing.